So I'd like to introduce David Butt. David is the CEO of the National Mental Health Commission. David's had diverse roles at a system level that have spanned the continuum of care, right across prevention, primary, ambulatory care, acute, subacute and aged care, and have involved him in policy development, planning, purchasing and providing services. He has a long-standing commitment to and involvement in mental health policy and service delivery, both at a health systems level and relation to specific programs such as Headspace, ATAPS and community and acute care services. David is also a former chair of the Australian Health Ministers Advisory Council. In January 2014, David was appointed as the CEO of the National Mental Health Commission, and the National Mental Health Commission is tasked with a review of mental health services and their funding. So we welcome David to the stage to be able to give us an overview of this really important piece of work. Welcome him, please.
Thanks, Pauline, and thank to all of you. And could I just acknowledge the traditional owners of the land on which we're meeting and pay my respects to the elders past and present. And could I also, given the topic that we're dealing with, also acknowledge those people with a lived experience who are such an important part of our system. As Pauline says, I'm CEO and Commissioner in National Mental Health Commission, and we have been tasked by the current government to undertake a comprehensive review of the whole Australian mental health system, which if I say it very fast, it doesn't sound like much. The Commission, just a little bit of background and before I get on to what we're doing now. The Commission was set up in January 2012 as a part of the reforms that actually included the establishment of Partners in Recovery, as a range of other things at the time. And it was really about the view about the need to have an independent body that could provide leadership, report, advise and collaborate on the mental health system, but particularly with a view to walking with consumers and carers, a view that consumers and carers felt somewhat dominated by, they believed that the voices of service providers and funders were dominating the system and that they wanted a stronger voice. And so in the first couple of years of the Commission, a strong focus on development of 2 report cards called A Contributing Life. Those report cards had 18 recommendations in them, 10 in the first one, 8 in the second one. By the time the second report card came out, there had been a change of government and we had been tasked with the review. But coming out of those report cards were a range of projects about what makes a contributing life, about developing leaders within the mental health system, about seclusion and restraint and how we can actually reduce the use of seclusion and restraint. We've been driving the work on peer workers and the development of a Cert 4 on peer workers, and we've also been, we took the lead on the development of the Mentally Healthy Workplace Alliance and the work that's been done with employers, employees, which have resulted in the stuff that's happening with Heads Up and a whole range of stuff with Business Councils of Australia and the likes. The review was a requirement from the federal government for us to look at services and programs to look at effectiveness, efficiency, red tape, overlap, gaps in services. So a strong focus on effectiveness and efficiency, nothing wrong with that. I mean, that's reasonable for a government to do that. But also going more broadly and saying you can go and have a look at what enables a contributing life. And so very broad in scope. So we're looking at federal, state, private, funding, we're looking at policy, we're looking at consumer and carer participation, we're looking at service provider roles, we're looking at whether it's health, housing, education, employment, welfare, relationships, justice system and so forth. So it's very broad, and our final report is due by the 30th of November. That will feed into deliberations by government, which I expect will come out in the budget next year, so in May. And it's a report to government, it's not a report of government. We don't know how little or how much of the report will actually be accepted by government, But I think it's actually a pretty exciting opportunity because one of the good things about it, I think for a start, was that the National Mental Health Commission was asked to do the review, so it wasn't actually given out to an accounting firm or some other body, some business entity or whatever it might be to actually have a look at it. And it was very much a view about wanting to ensure that government expenditure on mental health is spent wisely. And I actually think it's a genuine concern from government that there's been lots of reviews about mental health. There's been lots of recommendations made, and obviously we still have major challenges in relation to mental health and suicide prevention. I think there's a strong myth about mental health that I think is an important one, and one of the ones we want to deal with in our report. There's a whole range of myths in relation to mental health, but one of them is that the sector is very divided and doesn't know what it wants, and I think actually that's just not true. I think the directions in relation to policy reform are quite clear. You talk to consumers and carers, such as I'm sure there's plenty of you here today. There's quite a clear direction about wanting to focus on prevention, early intervention, and certainly always a pathway to recovery, and that in fact the current system is somewhat lopsided. And in fact, I mean, one of the things we've been looking at is Commonwealth expenditure, and Commonwealth spends almost $10 billion on mental health directly, but that's in areas such as disability support payments, carers payments, acute care payments, MBS, PBS. Most of those areas are rising pretty rapidly, except for PBS. PBS is not rising, but that's because of issues beyond mental health. It's to do with price disclosure and drugs coming off patent. Although having said that, we are very high users of pharmaceuticals. We're the second highest users of antidepressants in the world. The only country that's higher is Iceland, and you can sort of understand Iceland. I hope there's no one from Iceland here. But you can't understand Australia being second, but we actually prescribe enough antidepressants to keep 10% of the population on them full-time all year. Our use of antipsychotics has quadrupled since 1990, but obviously prevalence hasn't changed. So we're actually seeing antipsychotics being used for behaviour management in children, being used instead of benzodiazepines to help people sleep, and also being used for dementia. And I don't know how good the informed consent is about the potential physical impact of the use of antipsychotics on people, but particularly with children, that certainly has to be a major concern. So pharmaceuticals, what I think I'm touching on in terms of some of the findings from the review is that we spend a lot of money downstream in terms of picking up people when they get ill, particularly through the acute care system, the crisis system. We don't do enough upstream to keep people well in the community and operating, and we don't wrap services around them. We tend to medicalise problems, so that if you look at range of people who actually have a mental health issue each year, and there's about 3.2 million people a year, and obviously a lot of them are young people, adolescents, young adults, and the level of severity of the various mental ill health issues that they face obviously varies, but we tend to pretty quickly put them on pharmaceuticals, refer them to better access, and label them as sick, rather than actually recognising that people often only need varying levels of intervention that may assist them, or actually to talk to people, a bit of CBT, something online, not necessarily being put on drugs and potentially staying on drugs for a long time. As you all know, one of the things that I still find, well, I think we all find somewhat disturbing, is the difference in approach to mental and physical health. I mean, mental illness, mental ill health, as you know, is very common, but there is still a great deal of mystique and, as I say, myth about mental health. But the way we deal with people with a mental health issue compared to people with a physical health issue is just totally different in the way we label people. We take away their freedom, we impose things upon them, we reduce their choice, we, as I say, medicalise them. If they've got something urgent, they often have to wait, whereas someone with something that may be actually urgent and a physical illness will get looked after very quickly. So there are a whole range of things that are actually not working very well in the system. So what we're looking at is how you actually shift things around, get the incentives right, shift things around in terms of system reform, and get that stronger focus on early intervention, prevention, and, as I say, always an approach to recovery. How do we actually make it a system that's focused on the needs of individuals, their carers and other support people, on their families, so that you're actually supporting them? How do we move away from the current approach, which, as you know, the sicker you are, the harder it is to often navigate the system? And that in many ways hasn't been helped by the range of siloed programs that have been put in place by various governments, state and federal over time, different funding incentives, particular areas where you've seen people who are particularly effective lobbyists, or where governments have had a particular focus on something, where particular programs have been funded, and so we've created more silos that people have to navigate. So how do we get around that? And fundamentally that actually does involve system reform. So principles that would, and obviously Partners in Recovery, that rings a bell with you in terms of the focus on both individual need and system reform. I mean, the individual need one was something that, of course, the previous government was very keen on focusing on, but as you are well aware, better than I am, often focusing on individual need through what you do in terms of the case managing leads to identification of system problems, and then you can obviously then lead on from that to actually do system changes that are going to benefit the whole system. So what we actually see when you look at the Australian mental health system is that we still have high levels of stigma, discrimination. That's been changing, but it's still a major problem, particularly in the workplace, and that's a focus that we've had in terms of mentally healthy workplaces. Primary health care, as I've already touched upon, general practice is pretty quick to go to a script. Their GPs are time poor. They don't necessarily have sufficient training or the actual integrated multidisciplinary team that can actually support people at the level that they should. States provide acute responses, crisis interventions, but in many states you've either got to have a compulsory treatment order or be in real crisis before you can get access. And what you've tended to see is a sort of gap widening between what's provided in primary health care and what's provided in the acute sector in the area that was traditionally known as community mental health services and child and adolescent community mental health services. And as I say, there's a widening gap there. To some degree, the NGOs have stepped into that area with their focus on psychosocial support. I would be suggesting that aside from that focus on, well, part of that focus on prevention, early intervention, we do need to be looking at how we strengthen that area of psychosocial support and those things that keep people out of crisis, and build up that community side of things, and also strengthen the primary healthcare side of things, but focus very much on, as a principle, having it very much consumer-centred, with an unrelenting focus on recovery. I think that unrelenting focus on recovery is something that is a challenge in a number of areas. If you look at what's happening in the reform, the review of welfare, if you look at what's happening with the establishment of the National Disability Insurance System, that scheme, it's a disability model where I don't necessarily think yet we've come to terms with how you deal with persistent but episodic chronic illness. How do you actually deal with that as compared to permanent disability? And I think we just need to be very careful in the trials that are going ahead and the transition that's occurring, that there's about the right cultural fit in that. I mean, the cultural fit should be about recovery. It shouldn't be about actually how do you maintain someone over the long term. And so I think we've got to be very careful that we don't want a service orientation all the time in what we're doing in some of these areas, but we actually want a recovery orientation. So I think that's something that, in looking at our review and what we report, and in dealing with the other reviews, we'll be taking a lot of focus on. So move from us would be very much about how you change your incentives to achieve the particular outcomes that you want to achieve. Potentially moving Commonwealth incentives over time, trying to get some clarity of roles and responsibility between the Commonwealth and the states, focusing, as I say, on how you build up that package of services that are wrapped around people to support them to stay healthy and within the community, recognising that mental health is a common illness or a common ill health issue like all sorts of other physical health ones as well. The two often cross over, they often coexist. One can cause the other, and that happens both ways. But we're not actually very good at integration and actually getting all of our different systems to work together around people. So for Partners in Recovery, it's interesting. That's one of the programs that we've been asked to provide advice on. We've actually been asked to provide advice on every program that the Commonwealth funds and basically everything that the states do. And to do that as much as possible on the basis of evidence. And that's as you would expect, not easy, because we actually haven't had an evaluation culture in Australia. Now, with PiR we do, but as you know, it's also very early days. You know, one of the things that Pauline and I were just talking about was that every time something comes up about mental health, the Commonwealth says, well, that's a matter for the National Mental Health Commission, and the list grows longer. So certainly there's a lot of focus on what we'll be recommending. I guess from my perspective, I'd say on it, I mean, Partners in Recovery was designed to fill a particular need, and you know, the feedback on it at the moment, and as I say, we're waiting for the evaluation outcomes. Feedback is that in some areas it's working really well. I mean, there's some fantastic models, great feedback from carers in particular and consumers about how it's working really well in areas. But as you would expect in a relatively young program, it's patchy. And so what you get is the sort of good stories and the war stories. And that's often an issue when you're actually dealing with perceptions in relation to government considerations of issues. So how do you actually deal with those perceptions? I suppose, and questions that come up about, you know, is Partners in Recovery another layer or another silo, or is it something that was designed because we are dealing with so many different layers and different silos? Can we look at system redesign that actually builds what Partners in Recovery does into your system redesign rather than identifying it as a separate program? Recognising that the functions that you do are absolutely fundamental, and that, you know, as I say, getting increasing amounts of good feedback, not a lot of evidence yet, but good feedback on the successes that are being achieved, but recognising that, yes, there will be change, and there is a desire from government to streamline, reduce red tape, integrate, coordinate, without having a lot of different silos being funded, but rather a smaller number of, hopefully, larger buckets of money available to wrap services around people and to support them. So a little bit hard to say on where we're going to go on things like Partners in Recovery, because like a lot of things, as I say, little available evidence, early days, and in many ways it hasn't had the opportunity to roll out over a long enough period of time. But you'd have to say the need was identified, and the functions are valued in terms of what you're trying to achieve and in what in many areas you are achieving. So I think just, again, confirming the importance of maintaining the value add that Partners in Recovery brings to the system is very well recognised. That doesn't mean that things are not going to change, and I think that's just something we need to deal with. I mean, there will be change. There is a desire. You've got a federal government that's very focused on state sovereignty, and is saying that they want the states to take on more and more of a role for service delivery. The Commonwealth has stepped back somewhat from that, potentially focus on providing funding and focusing on outcomes rather than funding things directly. I still think there's a lot to be said for regionally integrated models where you're looking at the whole range of services and resources available, looking at the needs of your population and then identifying flexible programs that can respond to those particular needs. So I think there is a lot to be said for a regionally integrated model of mental health networking that I think has a very strong place going forward in the Australian mental health system. Ultimately, I don't make the decisions, the federal government does. However, as I say, ultimately, there will be change. I think the important part is to actually recognise the ability to actually influence that change, because the change is going to be inevitable as, you know, you look at what's happening online, the ability to do different things remotely and so forth. The opportunities are brilliant. The thing we don't do necessarily very well within the system is change management. And when you think about change management, it's actually recognising that sometimes individual interests have to be subordinated to the better interests of those we're trying to support and serve. So what's the best way of actually building the platform to enable that system to evolve and develop, and then to keep on building on top of that, but always keeping in mind the needs of the consumer. So congratulations on what you've achieved to date. Exciting time ahead. I do think there's great opportunity. Thank you very much.